Yes, all right. Well, it's a pleasure to be here. And I think the last time I was there was 4 years ago in Munich. I unfortunately missed the 2 years ago edition, but it's good to be back and to share some of the recent work we did at Bloom Life and hear all the great innovations that have been shared already so far. So maybe just kind of a minute of introduction. I think it's been mentioned already, and I think no new information here in this audience, but we are in the middle of a pretty bad maternal health crisis, with maternal mortality rates being...
The mic, if it's on, we can verify it.
Let's see, it looks on. Test, 1, 2. Yeah, it's okay?
I think so.
All right, can you hear me? Yeah? It is not on mute. This is mute. Unmute. Yeah, it is unmuted. Okay, all right. Can you hear me? Yes? I'll try to speak a bit louder. So anyway, so we have this maternal health crisis. Maternal mortality rates are higher now than they've been even 40 or 50 years ago. And it's definitely bad in the US. I think it's been mentioned before. But it's also bad in Europe and globally, really. I think there are a couple of stats here. It's really across the board. UK really is not any better than what we see in the US. So I think there is that thing. And this is really just the tip of the iceberg. And so when we look at the space, we look at, so why is that? And so behind those dramatic increase in mortality rates, there is also, just underneath it, there is the increase in high-risk pregnancies. And so why do we have so many more high-risk pregnancies? You just have to look at the demographic changes that we see. Those changes are there in the global population. It's not something that only impacts pregnant women, but in the pregnant population, that leads to an increasing rates of high-risk pregnancies. Those trends, you all know them: increase in hypertension, increase in obesity, increase in diabetes, and in maternal health, we also have the increase in maternal age. And those demographic pressures all push up the rate of high-risk pregnancies. So that's really one component. And the second component of this is that while we have more women at high risk, which means more women that require more attention, we actually have fewer clinicians, fewer OBGYNs to actually cater to the needs of those women. And again, the situation is dramatic in the US. There is a stat here you see on the map. In red is all the counties where you do not have a single OBGYN. So county in the US, imagine that you need to drive to the next county. It's about 2 or 3 hours drive, right? So that means you need to, if you have kids, you need to find someone to watch your kids. You need to take some time off work, and you need to go next day to actually seek care, right? So this clearly is a huge issue in access to care. And the way we look at this at Bloom Life is like, so we set as our mission to really impact and improve the health of moms and babies, but we think that the way to do that is to rethink how we deliver maternal care. And so our thesis at Bloom Life really is that the future of maternal care will be remote, it will be data-driven, and will be proactive. We need to change the way we do things to have more focus on virtual care. I'm not saying only virtual. There will always be something, some part of it that will be in hospital, but there is a lot of it that we can do more visual. That will allow us to increase access to care. We can leverage a lot of connected devices, and I'll talk about this. This will give us access to real-time data, and we heard today a lot of different ways to analyze that data, critical decision support. It should be comprehensive. It's not okay to just look at one aspect. You know, there is the baby, there is the mom, there is the external factors. We need this holistic approach to actually understand what's happening, and it should be proactive. Like eventually, it needs to move towards managing the risk for pregnancy. In pregnancy, it needs to be about managing risk factors and take interventions earlier on so that we avoid the negative outcome for moms and babies. And so, I think this is kind of our thesis, what we recognize. And so the way we're approaching this at Bloom Life is we developed a program that we call Bloom Life Connects. Bloom Life Connects really is it's a comprehensive solution for remote maternal and fetal health monitoring that we try to tailor to the needs of every woman. Today, Bloom Life Connects has 3 programs. One is around managing hypertension. The other one is about managing diabetes, and then we're working on launching a third one, which is about it's about more fetal and non-stress test monitoring. So the first 2 is really about managing maternal health. The third one is really about managing fetal health. And of course, the 3 of them are working together to decrease the risk during pregnancy. So what's underneath it? So what we developed is a tech-enabled remote monitoring platform. This is kind of a high-level view of the architecture of the platform. So we have on one side, on the mom side, all the connected devices. I'll talk about our own device, but we also integrate other devices. We're just trying to contribute where we think there is a gap. There is a patient app, which you have some educational material. You also have some clinical surveys for the mom to answer. It's especially important, for example, if you want to screen for postpartum depression. It's important to actually bring those those surveys to the mom. So this is something that we can do through the app. Then there is a part that is in the cloud. So all the data that's collected with the mom will go and be sent to the cloud where it can be analyzed in real time. And then the cloud then goes into an integration into the EMR. So we're going to do a native integration into the software that are used today at the hospital. Again, the idea is to really fit into the existing hospital workflow. There is also the possibility to have an additional clinical service, especially to tackle the clinics that are especially short on staff, that needs additional support to help in the management of those patients. That's something that we can also do based on the platform. So just maybe very quickly about these different programs, the diabetes management program. So there we're using existing existing blood glucose monitors. This is one example here with a finger pick. We're working on integrating with CGM as well. But all the solution we've developed is really about integrating and facilitating the management of the diabetic solutions for moms and the doctors. So there'll be SMS reminders for the mom. There'll be clinical feedback provided to the mom. As I say, we integrate with healthcare systems. We do implement the clinical protocol. So if a clinic or a doctor has a certain way that she or he manages her patients, we will basically implement that in the cloud so that we take that, we automate it so that we make it easier for them to manage the patient. Very importantly, on diabetes, we also have integrated logging of food and meals. The blood sugar is an important information for sure, but it has to be contextualized. This was mentioned a couple of times before. In this case, it needs to be contextualized about what time of the day. Is it a fasting measurement? Is it a measurement after a meal? And if it's a meal, what type of meal have I had? So it's important to bring that information together and again, integrate it from the patient's perspective all the way to feeding into the doctor. On the hypertension management, it's similar. Here we're using traditional blood pressure cuffs. Again, for us, we're agnostic to what blood pressure cuff we're using. Today, most of the interest right now is on cellular-enabled blood pressure. It makes it very simple. So cellular-enabled device, you don't need an app. So that basically take a measurement. It goes directly in the cloud. That works really well in rural area in the US where some people may not have necessarily access to smartphone or to plans. So in this case, there is no app. We just interface with text message. It works super well. It's super easy. There is no setup. So that's really something that helps, again, the access to care aspects. And a lot of our users are Medicaid users. And this is really something that's very easy for them to use. Similar things, integration with healthcare systems and customized clinical protocols. So that's on kind of what we have live today. And then, maybe that's interesting. So we did a comparison with the first, I think, 500 users that we had, and we did a retrospective study. We compared that with similar users before we deployed our program. I think it was really interesting to look at. It's early outcomes. It's not yet like I would say hardcore clinical outcomes, but these are indications that those type of connected care program will help in managing patients. So what we've seen here is an increase in adherence. That's just adherence in taking their blood pressure. Like if you're hypertensive, you have to measure your blood pressure. And with this connected care program, we just see an uptick in adherence just in taking that blood pressure measurement. So that was the first finding. Another thing that was very encouraging is that we also see a reduction of the number of patients that have their blood pressure outside the control zone. So if you typically define like the high blood pressure as 160 measurement, for example, we're measuring like how many patients can stay within control. And we also saw a 30% reduction in poorly controlled blood pressure, which was very encouraging as well. Something that was also interesting as part of that pilot, we also tested reimbursement in the US, and that we had very broad coverage, almost 95% of reimbursement coverage of that program, which was also very encouraging. Then, of course, for those who've known us for a while, we also have a core technology component, and so there is a device that we've been working on for the last couple of years, which is a device that has maternal and fetal monitoring. I think you will hear about some other devices, I think later on as well. Our goal here, our focus really has been on moving, CTG that's done at the hospital and having a technology that can be used from home. So everything we do is really focused on the home monitoring. The goal really is that. The goal is that, the clinical routine and the ST test that you do when you're high risk from 32 weeks onwards, you typically need to go and travel to the clinics 2 or 3 times a week, spend 45 minutes there. And, for a mom, it may be half a day or maybe a day off. Our goal is to bring that test to the home. That's eventually what we want to do. And so we've optimized the situation, the solutions that can be used by the mom. It's easy to use. The data is streamed to the doctor, and that's kind of where the analysis can be done. I think that's kind of the first application of our technology. I think something that really excites me the most is all the potential that we have. And I think Nicola mentioned some of the studies that they've done on fetal ECG. We really much have a similar vision. to say, well, when we start collecting that data longitudinally, what we collect in the end is fetal ECG, it's maternal ECG, is uterine EMG. This is very rich information that has seldomly been used. And so it really opens up a lot of potential, I think, in driving a more predictive approach using some of the biomarkers or physiological markers for different types of complications. I just want to share like two studies that have been done. One is a study that we did ourselves, that was a couple of years ago already, where we tried to use that data to see if we could have an early detection of labor. And so it's a pretty old study. It was published in 2019 at SMFM. And so there we basically used, you could see it as a physiological marker. It basically combines features of the EHG, so uterine EMG, and maternal heart rate, including maternal heart rate variability, to basically have a predictor for labor. So the whole goal here is that if you take a 24 hours window, can you predict within that 24 hours, at the beginning of that 24 hours window, whether the mom is going to get in labor? Why is that interesting? It's because then you could actually drive intervention faster. Like if you see that she's going to get into preterm labor, you could drive faster intervention and potentially prevent the preterm birth event. So that's kind of the philosophy behind this. So we published that, and then we pushed it a little bit further. We did a prospective study on 150 moms. That study hasn't been published yet, but some of the results are available on clinicaltrials.gov if you're curious. And so the idea was that can we then use a physiological marker to really have kind of a screening test for labor. And then there we compare that to a clinical exam that will conclude to labor. And we pretty much see, similar specificity and sensitivity in detecting labor that you would have in terms of a clinical exam. So that's kind of some of the work that we've done. Another work that I want to highlight is not by us, but it's one of our clinical group that we work with in Colorado. The PI is Catherine Kissler. I think it's a really cool study. It's where her work is really about how can we drive down the number of C-sections in the US. And one reason why you have C-section is the labor dystocia. So trying to see, can we find an indicator, a physiological indicator that would basically indicate us that it is a dystocia. So there is no reason to actually do a C-section. We should just wait a bit longer. And so her work is really going into that. And that's, again, very preliminary work that was presented 18 months ago, again, at SMFM, where she basically compared, a known biomarker for preterm birth, for infections, so interleukin-6, and she compared that with a feature extracted from uterine EMG. And so the hypothesis behind that is that can we see fatigue in uterine EMG muscle, or the absence of fatigue, that basically is or would be a predictor of labor dystocia. And I think that's a very small study, 10 subjects, very small, but it does show some correlation between the IL-6 levels and the EMG features, which again I think is very exciting. So that's just the beginning. There is so much to be done, but this is the type of work that we can do once the data and the technology becomes available. So I'll just leave it there. I think the goal here is like, we're launching this platform now. We're trying to help moms and doctors to manage high-risk pregnancies, but I think there is really something to do when that data become available to really enable a shift in how we're delivering care for moms and babies. And it's definitely not something we can do alone. I think, I'd love to continue talking with all of you here. And then we have our contribution is a tech platform, is some hardware. I can do all the processing, so really welcome collaboration. So if there is an idea that you'd like to try out and use the technology for, just reach out, and I would love to discuss. So thank you.
So thank you very much for this impressive overview, and I'm sure there are questions. So you mentioned you use AI and for predictive markers. What is the process with the FDA about this?
So this is all research work. I think the FDA is still trying to figure out what's the process around AI. I think they're a positive move, I think, where they're trying to move more towards regulating the process rather than regulating an algorithm itself. But we haven't submitted any of the AI work to the FDA. I think it's still very early. We don't really want to be pipe cleaning stuff there. But just going to see how it works, and then we'll figure out how to actually submit. But it will need to be for sure an SAMD application. Yeah, I can hear you.
So I think remote monitoring is really the way of the future, but I think there's also some very interesting workflow things that I've heard practices kind of be like, oh, I don't want your technology because how do you then do that next step? So they're home, we're using this in the States, we have a very big rural places, like you're kind of alluding to, that doesn't have a hospital or a doctor. So what are the real-time workflows within your platform to be able to signal that something is going wrong?
Yep.
And then the steps to then get that mom, into a facility. So I think that's some of the, things that are not necessarily thought out well in the
Yeah, I agree.
rollout that makes people, the consumer, the clinician, be like, oh, this is really great. I'd love to save mom 3 hours of driving or those kind of things, but how do I ensure safety when it's not good time?
Yeah, and so I 100% agree with you. At this stage, I don't think the issue is technology. I think the issue is workflow integration. So I totally agree. And the way we solve that, so we only active commercially in the US right now, and so the way we solve that is that before we onboard a clinic, we have to have an escalation protocol in place. And that is part of so when we onboard a clinic, we're going to understand the clinical protocols, we're going to understand how they work, and then we're going to define the escalation mechanism. And so the way the system works is kind of flags, so it processes the data automatically, it flags the alert, they decide like what type of alert they want to get. It goes directly into the EMR. So for them, it's the same workflow that they would if it was just a patient sitting in the hospital. And then based on that, if there is, and we've had a couple of cases where we had a case where a mom took a blood glucose reading and she was hypo and she fainted. And so the protocol there was the nurse needs to call her, which she did. She didn't pick up, and then the protocol says send ER. So they sent someone to her place and brought her to the hospital. And in that case, it's a very good example of why this type of technology really saved her life. Like for the same price, she was just there, and then nothing would happen, right? But I agree with you. You do need those escalation protocol, and this is part of the solution. You cannot just think of technology. Oh, it's cool. No, it really has to see how it actually works in the workflow of the doctor, the mom, the nurse, like everyone, all the actors. Yeah, absolutely. Yeah. Martin?
I found your data on zero diabetes management super exciting.
Appreciate it. Thank you, because I think it's not something you would expect even to be that impactful from the start. So just, this is exciting to see. I would love if you could share a bit more about, is it SMS you do and that seems to do the trick, or anything else you might share how this works?
Yeah, we were also super, because 2.6, like so we went from, I guess first the threshold was, the bar was pretty low. So the comparison was a mom who was giving a home, it was for blood pressure, not so hypertension, not diabetes. But so the mom was given a home blood pressure monitor, but that wasn't connected. So then if you look at the standard of care, that was the standard of care. So the burden was on her to basically write all the measurements. And then if there was a value that is high, the burden is on her again to call her nurse. To see, or wait the next visit, come up with the notes, and then, I had a couple of high readings, but then 10 days have passed, so it's too late, right? And so I think so a couple of things back to your question about adherence. I think what we think drive up adherence was, number one, for sure, the text message. She gets a reminder every time she needs to do like text message, I need to take my blood pressure. Okay, that really helps. But it was also for her, the fact that she knew she basically had that automated connection to her care team was very reassuring. And it really took like the burden off her shoulders to actually, it's my responsibility to say something goes wrong, to say, I'm being taken care of. My doctor's got my data. If I have a problem, I'll be called in. And that shift in burden is huge. Like it's really, for the peace of mind, it's really, really big. And so I think that's what we think to kind of drive up adherence. And we keep on seeing it now, like as we're expanding in the US. Yeah.
Thanks, Julian, for your presentation. Regarding labor onset prediction, based on what you know so far, how important is the completeness of the record over pregnancy to do good prediction of the onset?
It's important because we always did, when we did the onset, there's always a comparison to a baseline. So we compare like just the absolute, but it's always, because it was longitudinal, the study was a longitudinal study. So we start including the mom at 32 weeks, and then we'll basically follow her until delivery. And then the way the prediction works is like you take an hour, it was half hour, a 20 minutes window it was. And then you compute for each 20 minutes a probability basically to get in labor. And the comparison, because everybody's kind of a different, especially in EMG, like in uterine EMG, like all like the tone, every uterus tone is different. And so having a baseline was quite important in the
maybe you won't be able to get very early records, but
you don't need, it's not like you need like a tremendous, like you really just need a baseline. It's really hard to detect, again, because you have to filter for that physiological uniqueness of everyone. And so you need to get that baseline. And it really didn't take us, I think we used an hour of baseline when we built the model. And so it's really not that much, but you do need that baseline earlier on. So that was something that at least we saw.
Yes, I promise it's quick. I'm curious if with the prolonged issue of maternity care deserts in the US, and we also have this huge issue in terms of a lack of postpartum care, does Bloom Life extend into the postpartum space, specifically with the hypertension management and sort of kind of augmenting the lack of oversight that we currently have for the postpartum period?
Yeah, we didn't plan for this, but the answer is yes. So, and actually, some of the clinics will launch now. We have one clinic that just want to do postpartum, so which is not a good business model because it's much shorter. But it was definitely, and so we see that, and I think we see a lot more that continuity between antepartum and postpartum. Of course, more for the maternal parameters, but yeah, it's definitely something that we offer today. Yeah.
Okay, so then let's thank the speaker again.